Thank you for joining us today as we discuss glycemic dysregulation. Health services across Manitoba are provided in facilities on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This presentation is intended as general information to broaden the knowledge base and informed practice of paramedics across shared health. The goal is to ensure paramedics can utilize the knowledge gained and apply it to any patient care map updates. We'll start off with review of A&P, then review of some pathophysiology, and then on to management of glycemic dysregulation. Starting off with review of the pancreas, you'll notice there are little bumps along the pancreas, and these are called an islet of Langerhans as we may know them. Hormones are released into the circulation via the splenic and hepatic portal venous system, and digestive enzymes are secreted into the pancreatic duct and then into the common bile duct. Contained on each of the islet are the following. There are alpha cells that produce glucagon, beta cells which produce insulin, delta cells which produce somatostatin, a controller hormone within the pancreas which inhibits excretion of both the insulin and glucagon from their respective cells within the pancreas. There are PP cells or gamma cells which secrete pancreatic polypeptides acting as a regulatory hormone within the pancreas, GI secretions and motility, and finally have some effect on the hepatic glycogen storage. However, this effect is very limited. Then there's epsilon cells within the pancreas, as well as the stomach and other GI tissues, and these produce ghrelin, which is our hunger drive hormone, which makes us want to eat. Now onto issues of glycemic control, which come in two forms. No surprise here, hyperglycemia and hypoglycemia. Under normal physiologic conditions, the body responds to increased circulating glucose through the release of insulin to uptake necessary glucose into cells for utilization and metabolism. The storage of excess glucose as glycogen, known as glycogenesis, for release later when necessary in adipose and muscle tissues. And when the body responds to lower levels of circulating glucose, the release of glucagon is stimulated. Glucagon causes stores of glycogen to be released and converted to glucose. This is glucogenolysis to gluconeogenesis. Except for extreme starvation situations, the liver is the only organ capable of converting glycogen to glucose. With liver dysfunction, there can be an inadequate response to glucose with or without adequate glycogen stores. The liver and the kidneys contain enzyme glucose-6-phosphate, which causes glycogen conversion, but kidneys only work in extreme starvation situations. When we can manage both conditions, but the majority of EMS care focuses on hypoglycemia. We are going to quickly cover hyperglycemic states here as well. So we've discovered that our patient has hyper or hypoglycemia. Well, this means things aren't working right, so what can we do? A type 1 diabetic is complete failure of the beta cells to produce insulin, whether from a genetic deficiency, destruction of the beta cells by an autoimmune disease, or other causes of beta cell failure. This could include medications or a metastatic process. The key takeaways for a type 1 diabetic is the failure to produce insulin at all or in any effective amount. Type 2 diabetic is caused by varying degrees of insulin production and resistance to insulin itself at the cellular or receptor level. So glucose is unable to enter the cell. Diabetes insipidus is caused by excessive urination, and this essentially wastes circulating glucose stores faster than it can be uptaken by a cell. Primary causes are sourced from the pituitary gland or nephrogenic complications. This is caused from either a lack of antidiuretic hormone or resistance of the nephron to the antidiuretic hormone. And patients can urinate as much as 20 liters per day. Central causes from the pituitary gland include idiopathic, traumatic, tumor or neurosurgery. And nephrogenic or kidney causes can include toxic ingestion of medications, renal disease, hypokalemia, and it can occur in pregnancy. And the key takeaway is it's caused by excessive urination leading to glucose wasting. We also need to review gestational diabetes. Outside of lifestyle and pre-pregnancy risk factors, there are internal causes of gestational diabetes. The placental growth hormone causes changes in both skeletal muscle and the liver, which reduce the effect of insulin action and glucose uptake while stimulating further glucose production. Human placental lactogen increases production of insulin but also decreases insulin sensitivity. Progesterone decreases glucose transport into adipose tissues while also decreasing insulin sensitivity. Under normal circumstances, this supports maternal fetal growth and metabolism. But in gestational diabetes, it begins the perfect storm into which it leaves excess circulating glucose, which ultimately is delivered in large part to the fetus, as well as causing glucose wasting with the excess urination. Not unlike diabetes insipidus, but this is not due to the antidiuretic hormone. So when do we want to check that blood sugar level? We're easily distracted by the obvious, but we don't want to forget other causes of glycemic dysregulation. This could be caused by exercise, lack of food, stress, sepsis. Glucose is easy to check and a low threshold to obtain, so suspicion or other signs and symptoms of hypoglycemia should be investigated. So when checking for a glucose site to obtain a sample, we can look at many other places than just the finger. So first place we look is to poke that finger, but we could also look at poking a patient's heel, their earlobe. We can look at any of these places to get an accurate sample. So what are some things that can prompt us to checking a glucose level? It could be anywhere from a known diabetic medications, patient is an altered LOC, they're feeling unwell, nausea, agitated, aggression, weakness, dizziness, headaches, blurred vision, paresthesia, solemnness, acute changes in mentation, tinnitus, loss of coordination, dysphagia, ataxia. Really, any sign or symptom of a glycemic dysregulation or acute illness, we should be checking that blood glucose level. So we've looked into the patho of what can cause glycemic dysregulation, but how do we tell the difference between the presentations? Hyperglycemic emergencies and conditions. Let's talk about it. So everything we need to know in short form for DKA and HHS is on this slide, but it is quite involved, so let's break it down a little. So let's start with diabetic ketoacidosis. Absolute failure of insulin, either the production of or resistance to, along with the inability to utilize glucose in circulation, causes the body to switch to a secondary energy production through the breakdown of lipids. This causes the release of ketones or acidosis, compounding the already hyperglycemic state. Hyperglycemia and hyperketonemia causing osmotic diuresis and acidosis. It comes on relatively fast, 12 to 24 hours on average, and a DKA patient is known to be 50 to 70 mLs per kg fluid deficient, and that's 5 to 7% of their body weight, and that's an average body weight calculation. There is some questions regarding ketoacidosis and ketosis, and the answer is ketosis, though following the same pathway, is controlled and does not generate acidosis as diabetic ketoacidosis does. Hyperosmolar hyperglycemic syndrome, or HHS, is more complex and a little more insidious in its presentation. Patients take longer to show significant symptoms as the process builds. The patient has relative resistance to the insulin being produced, but it's not entirely resistant. Glucose is still being used at the cellular level, just at reduced levels. Metabolic needs are generally met, but are unable to manage or store the excess glucose in a normal manner, so decreased glycogenesis and increasing hyperglycemia. A slow build in hyperglycemic state causes osmotic diuresis over time, and this causes life-threatening dehydration. The catch to HHS patients is that because it comes slower, it's usually noted as feeling poorly or I must have caught a bug, etc. And not until the patient becomes acutely ill do they then seek medical attention or someone finds them. HHS patients are typically in an actual body weight fluid deficit of 70 to 100 milliliters per kg. Here's a general comparison of signs and symptoms for presenting conditions. Both DKA and HHS can experience polyuria and polydipsia. With DKA, dyspnea or hypocapnia is present. HHS and DKA can have abdominal pain, nausea, vomiting, though it's a little more rare at HHS. DKA is lethargic and confused, and HHS is altered LOC or coma. And a DKA develops within 48 hours, usually faster, and HHS develops over weeks and days to weeks. So the take home here is that major difference in time of onset differing between these conditions. So we know that the extreme patients are at risk, but what about the normal hyperglycemic patient? Do we need to worry about them at all, as much as we thought? And the simple answer is not really. Francesco et al. Did a wonderful job in summarizing hyperglycemia in the acute and subacutely ill patient. Acutely ill patients with blood glucose maintained between 7.8 and 10 did better than patients with tightly controlled levels of less than 7. Hypoglycemia was associated with an almost double incidence of increased mortality. Mild hyperglycemia was utilized by the body in stress situations while compensating for active illness or injury. Patients with a BGL of less than 10 were treated and had blood glucose managed to maintain below 10. Have consideration for your patient's overall condition, but if you find an incidental BGL greater than 7.8 and less than 10, it's likely of no consequence right then. If their condition dictates fluids and treatment as normal should be provided, just don't panic and treat the hyperglycemic in isolation. If the BGL is greater than 10, we may want to consider fluids for relative dehydration. In DKA and HHS, the patient's cells are dehydrated. They need fluids. The emergent life threat is dehydration. This is accomplished by balanced crystalloids. We have the option of normal saline and lactated ringers. There are differences. They may be small, but potentially significant. Saline contains only sodium chloride and in supraphysiologic levels. This may cause further solute drag out of the intracellular space prior to redistribution to the intracellular space. 1 to 2 liters are generally not harmful, but in larger volumes can worsen acidosis. Lactated ringers has a much more balanced composition, although osmolarity and content is slightly below physiological levels, it is well tolerated and associated with much less solute drag prior to distribution through the intracellular space, while replacing intravascular volumes as well. The key resuscitation we can provide in almost any emergent hyperglycemic state is to rehydrate our patients. The body has been robbing the intracellular volume to try and maintain homeostasis. They are critically dehydrated and require resuscitation, which begins with fluids. Administer fluids as indicated by hemodynamic instability and relief of shock symptoms. Do not administer more than 5 liters of crystalloid in the first hour of resuscitation for the management of DKA and HHS. Monitor them. Don't administer blindly and realize that most patients will not tolerate fluid load in this situation. In the context of DKA, these patients have a respiratory compensation for the profound metabolic acidosis present with the condition. Kussmaul's respirations are the body's attempt to compensate by blowing off excess CO2, which is a weak acid. This is in response to the added ketones, which are more acidic. The patients will do this naturally, and at higher respiration rate, the lower the EtCO2 will be. And our efforts should be directed at supporting the patient's intrinsic respiratory rate. They are showing you the way, so let's just keep following their lead. Assisting their respiratory pattern and titrating efforts to maintain their intrinsic EtCO2. Example is you begin monitoring and EtCO2 is at 11 millimeters of mercury. You aim your support at maintaining this level of EtCO2. Let's not panic, some fluctuating is normal. If we get to the point where respiratory assistance is required, we will be unable to ventilate the patient at their intrinsic rate. Instead, attempt assisting every second or third breath. Consider PEEP to aid in alveolar recruitment and enhancing gas exchange. PPV can be considered by passive oxygenation, CPAP, which is passive support, or assisting PPV. Let's now review hypoglycemic emergencies. When referring to the pediatric age group, this is any child that is greater than 72 hours of age up until 10 years old, and we will be treating anything less than 3.3. These levels seem a little bit different than those that we have targeted before, but this is based on PALS standards. And for the adolescent and adult group, this is anybody that is 10 years of age and up, and we'll be treating anything that is less or equal to 4. So let's not forget about that zebra. Those patients whose glucose routinely run higher, they may be in a relative state of hypoglycemia even while registering normal values between 4 and 7. The example is the patient who routinely reads between 11 and 14. They present to us as acutely altered LOC and fatigued, and their BGL is reading 5.8. They're technically normal, but over time their body system has adjusted to function at higher levels of glucose. For these patients, consulting with OLMS may be reasonable to trial the administration of IV dextrose in an attempt to rule out the cause of altered level of consciousness. When we talk about our treatment options, it really is dependent on the patient condition and presentation. They can be sleepy or fatigued, but ultimately, if they're able to follow instructions and protect their own airway, and with the ability to effectively swallow, oral glucose or food intake may be quite well tolerated and sufficient for our needs and quite safe overall. Ideally, we'll provide something with a mixture of proteins and simple sugars and some carbohydrates. Ultimately, anything with sugar will do in a pinch, but adding more than just simple sugar allows for a more sustained release of glucose to the patient versus a spike and a crash. POP is a viable option. The nutrition label will even tell us how much simple sugar the patient has received, but we are not able to use diet POP in this instance. The key takeaway here is to not focus on how much the patient takes in by mouth, but more to ensure they're receiving adequate intake before progressing further into a hypoglycemia, potentially threatening that oral route. But what about this patient? They're unresponsive and no realistic airway reflexes or no ability to coordinate and swallow. Oral administration is risky and could be harmful. So what other tools do we have in the toolbox? We have dextrose 10%, dextrose 50%, and glucagon. Dextrose 10% or D10W is safe and effective for all ages and titratable to effect. Remember that the dosing is an up to range and you do not have to give the full 25 grams just because their body weight says that they can take it. Evidence based in practice points towards patients having adequate response with a 5 to 10 gram intravascular dose. Administration of D10 should be done calmly and titrate to response. Patients whose normal values are targeted have less instances of severe rebound hypoglycemia. 50% dextrose or D50W has a few more restrictions, but it's now for the patient where we are actually concerned about fluid overload for this patient. Have the same consideration for that titration and administer slowly, 10 mLs, which is 5 grams at a time, and we're titrating to effect. Glucagon is our fallback. Glucagon is a hormone and it takes time to work. Hormones are a slow communication throughout the body. When delivered intramuscular, it is not really reasonable to expect a response before 10 minutes, and realistically even 20. So be realistic about our expectations if this becomes our treatment. Think of glucagon as like a safety net, and also consider your site of administration. First, we're going to talk about intranasal. Look at the condition of the nose. Is it optimal to receive medications? Has there been any trauma? Is there any cold or flu or secretions running from the nose that will cause the medication to flow right back out? Is there anything that is going to make this route suboptimal? Intranasal is compared to IM, but this should be considered our last line. It is variable and will work, but it is very unpredictable. Looking at intramuscular routes, we have the deltoid versus the vastus lateralis. Is there a difference between these two sites? The answer is yes. How much difference? Well, 7 times faster in the deep muscle of the vastus lateralis because it is a bigger muscle and bigger blood supply with less shunt in shock situations. So we've administered our medication, our patient is now fully aware, and they're telling us they want to refuse care. They can still refuse care. They were potentially in a spot that they would not allow them to have capacity to make an informed decision. However, the clinical situation is likely not the same. They now have capacity to make an informed conclusion. Parents or legal guardians can refuse care on behalf of their children, as well as medical proxies can refuse continued care or transport for the designated patient. This is a patient refusal. It is not, nor was it ever, a treat and release. We are by no means discharging the patient from the scene. They are refusing care. And that brings us to the end of our presentation. Thank you for sticking with us and discussing our topic of glycemic dysregulation. If you have any questions at any time, please feel free to reach out to our West Zone clinical team and we can have a talk with you at any time. Thank you and have a great day.